this is our Ask the Expert session on pressure sores. So I'm just going to go ahead and introduce our speakers in session today with Rachel and Lauren. I'd like to introduce you to HAPI Shield, a team of dedicated wound care nurses who are transforming how hospitals and long-term care facilities approach pressure injury prevention. They recognize that HAPI reduction strategies could be much simpler and more effective if staff were empowered with the right knowledge and training. The insight to lead at creation of HAPI Shield, a company specializing in pressure injury and reduction education. The team is led by Rachael Grace and Lauren, who bring extensive experience in crucial wound care. Rachael has 4 years of experience working in CTICU, CICU, MICU, and trauma ICU and wound care, while Lauren brings 10 years of experience in acute care and outpatient care and long-term care and wound care. Together, they provide a broad range of expertise and help healthcares and professionals improve outcomes and deliver safer and more effective patient care. So with that, I'll pass it on to them to start their presentation, and we'll have a Q&A session at the end.
Thank you so much for introducing us. Hearing you read our credentials, I am flattered with our experience. Aren't you, Lauren? Well, thank you so much. I'll go ahead and start sharing my screen.
So Grace and I actually, we worked together at a level 1 trauma center in Atlanta, Georgia. So that's where we met. And so a lot of our experience together is in the inpatient setting of wound care. And as mentioned, I have a lot of experience in other settings as well. So HAPI Shield as a company is really focused on, educating clinicians as well as, individuals and family members as well. So that's where the name HAPI Shield comes from. But we're definitely very excited to do more outreach and education on the community side as well. So we really appreciate being here, and thank you for having us.
100%. Thank you so much, Lauren. So our objectives for the presentation are, we're going to discuss pressure injuries and how pressure injuries are unique to the spinal cord injury patient population. We'll talk about evidence-based prevention strategies, specifically for SCI, and then we'll go through a case snapshot and go through the key things we want you to take home, and then we'll have time for question and answer. So pressure injuries and spinal cord injury. So first of all, why do we want to discuss pressure injuries and spinal cord injury? The reason is because 25 to 85% of people with spinal cord injury will develop a pressure injury at some point in their life. And the reason why this number is so broad is because there have been several different lit reviews or reviews of the literature that are out there, and they really range. But generally speaking, the literature is telling us that about 60% of people in their lifetime with a spinal cord injury will develop a pressure injury. And then let's run through spinal cord injury in Canada. I know a lot of the times we talk about the American data, so I wanted to make sure that we cover what's happening in Canada because that's relevant to you guys. So in 2019, this is the most recent review of the literature out there. The estimated traumatic spinal cord injury population was about 30,000, with about 15,000 being paraplegic and 14,000 being tetraplegic. So forgive me if this is repeat information, but paraplegic meaning the legs and below, essentially, and then tetraplegia generally being the neck and below being affected. So trends included an increase in the number of people injured because the study was a repeat of 15 years ago. And so they saw a 37% increase in the patient population in this study. All right, so then this is the National Spinal Cord, the National Spinal Cord Injury Statistical Center. And this is in America, just as a cross comparison. And this is out of the University of Alabama. And if you're interested, this is the most in-depth research study that takes a year. So in the United States, we have about 308,000 people who are estimated to be living with spinal cord injury, and roughly 18,000 new cases every year. And we have the patient population breakdown. Generally speaking, men are much more likely to have a spinal cord injury. And then we have different causes of injury, the number one being caused by motor vehicles, and the next being falls, and then followed by violence. And every year they put out a new infographic. So if you're interested in ever looking at the data from this year, that's available to you for free. And I have links to all of our resources at the end. All right, Lauren, what is a pressure injury?
Okay, so pressure injury is localized damage to the skin or underlying tissue due to pressure, of course, or pressure in combination with shear. So usually pressure injuries occur over bony prominences, but they can also occur over areas that are exposed to medical devices or other objects that are pressed against the skin. And shear forces, which are included in the definition for the National Pressure Injury Advisory Panel's definitions of pressure injury, are they refer to when opposite forces are applied to the skin. So basically, just in practical terms, like if you're in bed and you're sliding down the bed, the skin and tissues underlying shearing and sliding against the mattress or surface underneath, which creates a deep tissue injury under that. So for terminology's sake, a hospital-acquired pressure injury is obviously a pressure injury that occurs during a person's inpatient hospital stay, whereas a CAPI or a community-acquired pressure injury is a pressure injury that occurs while someone is residing in the community or at home. Other terminology, it's advanced and changed over the years. It's been called bed sores, decubitus ulcers, pressure ulcers. The most current iteration of that is called a pressure injury, because the thought process behind that is because it's more than just an ulceration or a wound. It's the injury of the underlying vasculature, the blood vessels that feed the skin, and the surrounding tissues. And especially with that incorporation of that shear force definition in with the wounds themselves, that's why they've more rounded the term to become a pressure injury. So common areas of pressure injuries, and we're looking at the X's on the little man there, would be like when you're lying on your back or supine, back of the head. So the occipital area, the shoulder blades, elbows, the sacrum, heels, and ischial tuberosities, or we refer to them in wound care as the sit bones. So the bones that you would be sitting on when in a chair or a wheelchair. And obviously, if you were to be prone, so laying on your stomach, there are also areas of bony prominence and pressure injury on the front of your body. So it could be, we see this in the hospital when patients are prone for, severe respiratory distress. We can find pressure injuries on the tips of the toes, the knees, the ribs, but typically, when we're looking at pressure injuries, the most common areas are the sacrum, the heels, and the ischial tuberosities. So considerations for individuals with darker skin pigmentation. This is actually something that we are working on studying at the hospital where I work now. It's an academic institution. And it was found that, and I have links at the end if you're interested in reading the study, but individuals with darker skin complexions are at higher propensity to develop a more deep or extensive pressure injury because staff or the individual themselves might miss that warning sign that a wound is occurring. So if you look at the NPIAP, the National Pressure Injury Advisory Panel's staging guidelines, initially it was referring to individuals with lighter skin pigmentation, and that even that combine, I'm sorry, that includes the terminology that's used. So you'll see in the definition of pressure injuries themselves, when they talk about erythema and blanchable erythema, that's not something that you might see in an individual with darker skin pigmentation. So a lot of those early warning signs aren't necessarily seen with the naked eye, and it's something that we have to feel and palpate for. So special considerations might be that something is change in temperature. It might feel boggy to touch. We call that. So, you know, a change in the texture or the consistency. And, you know, there might be pain or a coolness or a different sensation in that area. So the stages of the pressure injuries, this is just like a little diagram that just shows the different layers and levels of the skin and tissues that are injured when the stages go from stage 1 to hopefully never a stage 4. But as you go through, the stage 1 would be like that initial injury that we're seeing. You know, that's like kind of past that warning sign. So there's some tissue destruction that's occurred. That's when we're talking about the first layer of skin or the epidermis. It's non-blanchable redness on intact skin, or on an individual with darker skin pigmentation where you might not see blanchable versus non-blanchable redness. It might be boggy with no color change. And when I talk about blanchable versus non-blanchable, it just in case, you know, if you're not aware. So if you were to touch and hold on your skin for about 3 seconds and remove your fingers, your skin should change color. And if that's not happening, then that's considered non-blanchable redness, or by definition of the NPIAP guidelines, a stage 1 pressure injury. So a stage 2 pressure injury is going through that second layer of the skin, known as the dermis. So that the first layer being the epidermis is damaged. And now we're into a shallow ulceration in that second layer in the dermis, but we haven't hit that fatty layer yet. It might also be a clear fluid-filled blister that you might notice. A lot of times this happens on like the heels. You'll see that clear fluid-filled blister, as opposed to the buttocks, ischial tuberosity area. You might see that shallow, open, pink crater, which is the stage 2 pressure injury. So when we hit stage 3, that's considered a full thickness open wound. So it's to the layer of the adipose, our subcutaneous tissue. So, you know, once we get through there, you see in the picture, it's kind of gone through that vascular layer of the dermis. And in the subcutaneous tissue, once we get to that portion, a lot of the vasculature is, you know, to say it kind of bluntly, fat is not very well perfused. So once you get to those deeper layers of the tissue, the wounds just get harder to heal. And the longer a wound is open, the more difficult it is for it to heal as well. So stage 4 pressure injury is when there's some sort of structure exposed. So the bone might be exposed, the tendon might be exposed, or the muscle. You know, that's obviously a very extensive pressure injury. It could be very deep, depending on the part of the body that it is, or it could be very shallow. So for example, a person might have a stage 4 pressure injury that's on their bottom that reaches the bone, that's quite deep. And you might hear of, you know, healthcare workers that work in hospitals and say that, you know, their patient has an open wound and it's something that you could stick your fist in. But if a person has a pressure injury, say on their ear, that's very superficial, and you would hit structure like cartilage with only just a few millimeters of tissue being lost. So the stages don't necessarily refer to the depth of the wound, but what's exposed underneath. So once you hit a stage 4 pressure injury and there's some sort of structure exposed, then typically it's very tough to heal. A lot of times you'll hear individuals that might need surgical reconstruction, negative pressure wound therapy or a wound vac, or muscle flaps if it even gets that far from like a plastic surgeon. So a lot of times, these wounds are quite extensive and take several months to heal. A deep tissue injury is, it's also a non-blanchable area, but it's more purple. So deep tissue in stage 1, we kind of treat them similarly. So we want to protect the skin and try to make sure that it doesn't open up and get any worse. But oftentimes deep tissue injuries are, and you kind of see it from the diagram, it's purple and intact on the top, but underneath there's a lot of tissue destruction. So we often refer to them in wound care as like an iceberg. You don't really know the depth or the extent underneath until it kind of evolves and shows itself. So a lot of times for these type of injuries, we focus on just pressure reduction, keeping the skin as intact and clean as possible. A lot of deep tissue injuries I see in individuals with spinal cord injury tend to occur with shear. So those shear forces like sliding down the bed, like I mentioned initially, or that occur during transfer. So, lateral transfers from bed to operating table or lateral transfers from bed to chair. That's a lot of times where we see those shearing injuries. So a mucosal membrane pressure injury, we see those often, usually in concurrence with the use of a medical device. So these aren't staged per the National Pressure Injury Advisory Panel's guidelines because the construction of the tissue is not the same. So we just call them mucous membrane pressure injuries. So those can be located on, areas of the genitals, the mouth, lips, tongue. A lot of times we see those pressure injuries in the mouth and the oral mucosa when a patient is very sick and in like one of our surgical ICUs. So if they're intubated or have some sort of a nasogastric tube, but we do see a lot of pressure injuries on the genitalia from some catheters, catheter securement devices. We use a lot of external catheters in the hospital as well. So, condom catheters or Texas catheters, whatever they're called. And we have something called like a PureWick or a Primo Fit. They're more of an external suction device type catheter that's used for collecting urine. So, they're like I said, they're not staged and they're just called mucosal membrane pressure injuries, typically with device related. So medical device related pressure injuries can not just be on some of the areas that I mentioned. Anything that's a medical device can cause a pressure injury if it's compressed on the skin, like in this patient here, the IV tubing, sometimes just little folds or wrinkles in the sheets or chucks, especially if a patient is very ill. If a patient lays on a cap from an IV flush, even the boots and things that we use to offload individuals' heels. So there's like the offloading boots that have the little cup for the heel to sit in. I've seen those cause injuries on patients' Achilles area. If the patient has excessive swelling, these can also come from non-removable devices like casts if there's some sort of an orthopedic injury. So anything that's a medical device can cause a pressure injury if it's not offloaded properly.
Yeah, thank you so much for that, Lauren. So now we'll move into the physical exam portion. And this is a lot of information, I understand. But we kind of wanted to give you guys the perspective that another healthcare professional might have when they're looking at a patient to determine what their risk is for getting a pressure injury. So overall, or constitutional symptoms, we want to know, does the patient have an active infection or do they have a diagnosis of sepsis? Anything that changes the patient's metabolic rate can influence wound healing. And so that's one thing we look at. We look at, does the patient use oxygen, or do they need any kind of oxygen delivery devices like a CPAP or a BiPAP machine that can delay wound healing as well? Do they have peripheral venous disease or a condition where there's edema or fluid shifts happening in the tissue, like CHF, or that would be heart failure? And do they have good perfusion to the extremities? So we're looking, do they have capillary refill, and so on. Another thing that we look at, as Lauren mentioned, shear is a big problem for patients who have spinal cord injury. And so if you have to have the head of the bed be elevated, let's say, for example, to reduce their risk of choking or aspirating, then you might have that movement over and over again where the patient is falling down in bed, and then that shear action can happen, especially on their sacrum or on their spine. We also look at issues with toileting, because if you have diarrhea or loose stool or a bowel regiment program that is causing skin irritation, because anytime we change the pH of the skin, we're changing those natural defenses that keep the skin intact. We want to make sure that we have that solid barrier that would prevent a pressure injury from happening. And again, as Lauren just mentioned, we use different devices to contain stool or to contain urine. And so if we're using those devices, are we using them correctly? And are they in a space where the patient can maintain them? And then just as a note, older adult skin, 65 plus is the cutoff. I'm not saying that's an older adult. That's what the textbooks are saying, just FYI. So at 65 years and above, we have reduced vitamin D production. We've got reduced sensory function and thinning of the adipose layer. Now, why does that matter with thinning of the adipose layer? That's your fat layer. So that's your cushion. And so we have seen in the hospital people who are very slight of frame, malnourished, and they don't have that natural cushion that's going to keep their bones from putting pressure on the inside out. You can have a pressure injury that forms from the outside in, and then one from the inside out. The inside out is that deep tissue injury that Lauren mentioned. And that is like the iceberg, where you don't know how deep it is until it develops and shows itself over time. Another thing I want to mention here is decreased cell senescence. And this is essentially cells knowing what they're supposed to do, that they're to divide and stop dividing. And if they don't stop dividing, they can become cancerous. And so at 65 plus, that's a risk. And then I also want to mention that we have outside factors like smoking, which over time, we know can really cause a whole host of problems, but in your skin, you can also develop issues as well. We have decreased perfusion, we have higher risk of skin cancer, all kinds of things. And then if you've been exposed by the sun over a longer period of time, you can have damage to the skin, and also diabetes can cause damage, because if we have extra sugar that's in circulating throughout the body, it will cause microvascular changes or changes to the small vessels. And the small vessels will deliver oxygen and nutrients to the farther areas of our body. So, for example, you'll see issues in the extremities or the toes, the heels, the bottoms of the feet for older adults. Now we're going to run through some risk factors for pressure injury. We've got smoking, alcohol, drug use, diabetes type 2 or diabetes mellitus type 2. Inactivity, obesity, cachexia or anorexia, and this is basically being malnourished, that you're not getting enough to eat. Spinal cord injury, which is why we're talking about pressure injuries with spinal cord injury group. Cardiac disease, again, issues with perfusion can cause problems with oxygen and nutrient delivery to the tissues. Renal disease, low blood pressure or hypotension, infection, urinary fecal incontinence. And again, this is because if we're altering the pH of the skin or we're causing skin irritation, that will put you at a higher risk of pressure injury. Hypo or hyperthermia. So we're going to talk about this in a minute, but we really have a climate to our skin that we want to keep intact. And so if your skin is has the vessels, the small vessels that are reaching it, be constricted, then it's shunting necessary oxygen, nutrients to your organs. And for hyperthermia as well, if you're having a lot of sweat, you can have issues where if you're overhydrating the skin in the folds, you're at a higher risk of developing a skin infection or skin breakdown. We'll see that something called intertrigo, where in between the skin folds, you'll have skin damage and erosion of the skin, sometimes accompanied by a yeast infection or a fungal infection. Low serum albumin levels, and that's just correlated with if you're having enough nutrition. I believe there's other aspects to albumin that indicate what is going on with your metabolic status, but I won't dive into that too much here. And then impaired cognitive function, where if we have a patient who has dementia or is altered in some way, they're not necessarily going to turn themselves as much as they should. When their body is sending them the signal that it's time to turn, you're experiencing pain or discomfort. Of course, impaired vascular function, as we've mentioned, and impaired oxygenation, because if you're not getting oxygen to the tissues, if anybody's interested, the process of phagocytosis, or by which that white blood cells will take action to take care of infection, it requires oxygen in that process where it's your white blood cells envelop an infection. It requires oxygen to do that. So if you have impaired oxygenation, you can have impaired or delayed wound healing. Next, we're going to run through how do we predict a pressure injury will occur. So I spent a good long while on this one, and this is something that I was not as familiar with in relation to spinal cord injury if there was a specific scale. So I looked into it myself, and there's a few ones that they've tried over the years, but none have been validated as a tool to predict pressure injuries in spinal cord injury patients. And there's one called the SCIPUS tool, and I've linked to it in the end, and it's the spinal cord injury pressure ulcer scale. And they claim that it's or the creators of the scale claim that it's the most accurate tool for patients in a rehab setting with a spinal cord injury, but it's never been validated. So the most widely studied pressure injury risk assessment tool is the Braden. And the caveat that I'll give you with this is that the subscales for how you grade whether somebody will have a pressure injury or not are generally all affected by a spinal cord injury. Your sensory perception, your moisture, activity, mobility, friction, and shear. I'm sure you can see how these ratings might work for another patient population, but for spinal cord injury, generally the answers for all of these is going to be impaired, slightly impaired, or totally limited in terms of your sensory perception, activity. It just depends. But that's why it's not necessarily considered to be a very reliable tool to use with spinal cord injury. And the score to indicate risk is less than 18. But as I've mentioned, as clinicians learn about pressure injuries, we want to empower them to look at the whole patient picture of what is their risk category if we look at them from head to toe, not just using one of these prediction scales.
If I could just jump in, Grace.
Oh, please, go ahead, Lauren.
For that, and actually what Grace was talking about specifically with the Braden scale and the low scoring. So this is something that we, when I educate nursing individuals and clinicians, this is something that we really drive home because obviously in a level 1 trauma center, we have a lot of individuals who are either acutely diagnosed or who have been living with a spinal cord injury that come into our hospital. And we really try to drive home the scales are nice, but scales themselves don't prevent wounds because a number versus the individual, it might not match up. So an individual who's living with a spinal cord injury might have a lower scale on the Braden, as Grace was mentioning, but this person might be totally independent, whereas you would do the Braden scale on somebody who's in like the ICU setting and they would score low. So just because an individual has a low score, so like if we're talking about 12 or less being a very high risk, just because a person might score lower, it doesn't mean that they're not a fully functioning, independent person who can manage all of their toileting and ADLs on their own. But they're not, that doesn't put them any less at risk. So that's something that I always make sure when I'm speaking with clinicians is that individualizing plans of care is very important, but especially with individuals who have spinal cord injuries, and just listening to our patients, because they know their bodies better than us and they tell us their routine. I always, when I go and meet my patients, I always ask them, you know, like I check out the chair, ask what's the routine, how do you get from bed to chair, you know, what's changed now that you're in the hospital. Is there anything that I need to do for you to change? You know, like, is this cushion still working for you? Is everything still, you know, as it should be for you, or are things changing? So it's definitely something just to be individualized. So definitely very important.
Yeah, thank you so much for clarifying that, Lauren. I appreciate that. All right, I'll run through quickly the new technology alert. So Lauren actually pointed me to this article. So something to look down the line is, can we predict whether an individual will have a pressure injury based on a blood test? And so essentially, there was a study that was done with 30 patients. 15 had a spinal cord injury and did not have a pressure injury in the past. And then 15 had a spinal cord injury and did have a pressure injury in the past. And so they measured all these different biomarkers, and the one that was the only biomarker that was clinically significant, that had a clinical significant difference, was the FABP4 marker. And so this is something to look into in the future, as potentially you might be able to take a blood test one day and they can say, oh, because you have a higher biomarker in your body, we might consider that you would have a pressure injury risk versus someone who does not have the FABP4 biomarker. All right, evidence-based prevention strategies. So we have here our little wheel for preventing pressure injuries for patients with spinal cord injury. So we have come up with assessment, support surfaces, nutrition, microclimate, repositioning, and protective dressings. And this is based on the MSKTC guidelines, the spinal cord injury guidelines from the most recently published wound care textbook that we use, and the NIPAP guidelines, the international guideline. So for assessment, we recommend that daily you check your skin for problems or changes, and especially note those areas that we mentioned before as being the most common areas of pressure injury. For support surfaces, the international guideline recommends that mattresses should be replaced every 5 years, especially in a hospital setting when they have patients who are like multiple different patients who are using the same bed over time. And then they recommend offloading devices like heel lift boots and pressure relieving surfaces for those who are in a bed or a wheelchair. And then I've got more specific recommendations if you're in a wheelchair. So for wheelchair support surfaces, the MSKTC guideline recommends every 2 years getting a seating evaluation for proper cushion and wheelchair fitting. In the United States, I'm not sure how available this is in Canada, so forgive me, but they use pressure mapping to teach weight shifts. So maybe you guys could educate us a little bit later to let us know if you've done pressure mapping before. And basically what it does is, in the first picture, you can see the red areas over the ischial tuberosities where the patient is sitting. And the pressure mapping shows that if you remain in this position, you're going to have increased pressure on those areas of the body. And so they teach you how to sit in an ideal position that would decrease your risk of pressure injuries. And if pressure mapping is not available, there are professional seating experts who can try different cushions to try to offload pressure as best as possible. Then for nutrition, we recommend eating a balanced diet. Patients with spinal cord injury really may benefit from working with a dietitian, especially if you have a pressure injury, because there are increased protein requirements and caloric requirements when you have a pressure injury. And we also need to make sure that patients who have pressure injuries are getting enough fluids, not just food as well. And then if there's any question as to whether a patient has been eating enough and their nutritional status is optimized, a doctor might order a blood test to check albumin. And then we've also found in recent years that prealbumin, which is like a precursor protein to albumin, might be a better indicator of nutritional status. They might look at lymphocytes or hemoglobin levels, and based on those blood tests can tell if something is off. Now let's talk about microclimate. So microclimate is the skin flora, temperature, and pH, and all these things work together to repel water and prevent infection and breakdown. So just as we were mentioning before about if we don't take care of urine or stool containment, then it can change the pH of your skin. It can change the kind of bacteria or the skin flora that is present. And so we want to make sure that we use your body's natural barrier methods to prevent pressure injury. And of course, broken skin barrier means that skin is at risk, and moisture-associated skin damage. So this is the general term for when we have a patient who is sweating, who has urinary incontinence, or maybe it wasn't cleaned properly, and the moisture has caused damage to the skin. Another name that you might be familiar with is incontinence-associated dermatitis. And so that's just the term for if we have a patient who they're not having their stool or their urine contained and it damages the skin. And then they're at higher risk for yeast infection or bacterial infection as well. All right, and bed positioning. So generally speaking, according to the international guideline, turning for patients who are bedbound is recommended to be every 2 to 4 hours. But recent research is showing us that an individualized turning schedule is most appropriate. Just like Lauren indicated earlier, we are finding that individualized care plans are better than saying everybody needs to do the same thing. And then I've got this QR code for the international guideline. If you're interested, I think it's about 100 pages. So it's pretty in depth, but if you're interested, feel free to scan that. And I'm going to try to fly through these a little bit quickly so we can make sure that we have time for questions at the end. For wheelchair positioning, the MSKTC guidelines recommend that every 15 to 30 minutes, for a duration of at least 30 to 90 seconds, you perform a pressure relief. And this is a great guideline that I've got the QR code to. It shows how to do these tilt and leans to offload pressure, whether someone is tetraplegic or paraplegic. And you want to make sure that your feet position are correct, or that your feet are correctly positioned, because what we are finding with patients who who spend most of their time in a wheelchair is the Achilles tendon is really vulnerable. And I know I've seen patients with spinal cord injury get an Achilles tendon pressure injury, and it's so difficult to heal. It's like right against the skin, and want to make sure that we can prevent that. And then usually when you're at the hospital, and again, I would be very interested to hear your experience that in the hospital, did someone teach you how to do pressure reliefs? Or was that something that happened at rehab? That would be very helpful to know what your experience was. And then a hot tip is using your smartphone timer or an application to remind you to turn. I just gave birth about 4 weeks ago, and like remembering to take care of my infant is very difficult for everything. Like, have I burped you? Or did I, when was the last time I fed you? When did I sleep? So I know that I generally take better care of someone else than I do myself. And so if that's my case, I know I need a smartphone reminder. So just wanted to encourage you guys to use all the help that you can get. And then, Lauren, will you cover our protective dressings for us?
Sure. So in the hospital setting, a lot of times we'll use these foam dressings, and that's kind of like the hot topic now in the international guidelines, using these 5-layer foams that, especially in shear prevention, because the foam layers move against each other as opposed to the skin moving against a surface. So they're thought to prevent shearing injuries. I think the last statistic that I remember reading was around like 13% improved prevention. But the use of this at home might not be very feasible or cost effective because these dressings are not very cheap and they're not necessarily easy to come by. Aside from offloading and relieving the pressure, like Grace had mentioned earlier, a big precursor to pressure injuries, especially like on the sacrococcygeal area or the ischial tuberosities, is incontinence-associated dermatitis. So a lot of what we focus on, and something that we're currently studying right now, is just the use of different barrier skin applications. So, the tried and true, the zinc is something that we've used a lot for a very long time, but now they have this newer, it's not necessarily new. If anyone is living with an ostomy, they're familiar with the acrylate, they call them, type dressings known as Skin Prep or Cavalon. So there's a lot of research that's been done very recently by the Wound Ostomy Continence Nurse Society on the use of these acrylate dressings over areas that are at increased risk for incontinence-associated dermatitis, friction, or shear to help protect the skin. So what it does when you apply it, the Skin Prep, that's like the main brand, like if you called it like a Kleenex. So Skin Prep, if you apply it and you let it dry, it's basically like a second layer that's clear, see-through. If water was to spill on the skin with the Skin Prep that's applied, it beads right off. It moves with the skin, as opposed to like if you were thinking like a liquid bandage that just kind of like stays on top of the skin. And it doesn't have to be applied every day. In the hospital, we put it on every couple of days. So it's something that it's gaining a lot of traction and research to be used as prevention. And a lot of hospitals even in Georgia, right around the corner from where we work, is a very big spinal cord injury rehab center. And they actually use this on all of their individuals there for prevention. The Skin Prep, they apply it every like 3 to 5 days. And it's just this clear layer. So the skin is not, doesn't have this thick zinc paste that you have to try to remove and check underneath and, see is there any color changes. And like I said, it really helps with that friction prevention as well. So that's something that's like the new hot thing in wound care. So time wound healing, just to kind of like run through this really quick. This is how we as wound care clinicians pick a treatment plan for if a patient does develop or an individual does develop a wound. So it's just an acronym that goes through like how are we moving throughout the phases of healing and addressing things in the wound to make sure that it comes together and closes. So the T in time being tissue. So we're looking at the wound base, seeing is there like necrotic or unhealthy, non-viable tissue that needs to be removed. I is the infection or inflammatory phase. So a lot of times chronic wounds, so wounds that have been 4 weeks or longer in duration, are stuck in this inflammatory type phase and need a little push to get out of it. So the types of dressings that we choose, they might be antimicrobial, they might be some topical or systemic type of debridement, or antibiotics if clinically indicated. And then M is the moisture imbalance. So when we're looking at, just like we're mentioning with the skin, we don't want overly hydrated skin. We don't want a wound that's too wet or too dry. We want it somewhere in the middle, just right. So what dressings can we use that either donate moisture to a wound if it needs it, or removes excess moisture if it needs that as well. And E for edge. So the wound edges need to be open for the epithelial cells to migrate across the wound bed. So we need the edges to be open. A lot of times you'll see a built up or closed edge in a wound that's chronic, or if there's a lot of shearing forces at hand. So that's something that we're really mindful of, is just maintaining an open wound edge to try to help encourage healing.
Thank
So I just have a question. The deep tissue pressure injury, with somebody who doesn't have an SCI but is a wheelchair user, let's say, has a different condition, has a sensation all around. Can this deep tissue injury be felt? Let's say if it's like closed off on top, but it's actually protruding all the way down. So is there a sensation of pain or not during this one?
That's a really great question. So a lot of times, the more extensive a wound is, the less painful it is, because the deeper layers of the tissue are already affected. So a lot of times people, individuals that have deep tissue pressure injuries, they will feel some sort of a pain in the leading up to it. But by the time that purple tissue is there, a lot of times they don't necessarily feel it anymore. So usually in the build up to that purple, you have that like red non-blanchable erythema, like that stage 1 that's kind of occurring. There are like, say if a person develops it in their heels, I have had just anecdotally patients tell me that it feels like tingly, or something itches, or something just doesn't feel right. But that's a great question, because like deep tissue injuries, like we talked about, they're typically more extensive, and they tend to be very insidious in their presentation. So it can be kind of just like that, especially if it's a shearing force injury. So it might not necessarily be felt. But for like an individual, like for me as a healthcare professional assessing on another individual, a lot of times for me, the sensation of the coolness, the bogginess, that's always there. So it might just be the palpation of like just your fingers pressing on the area itself. So looking and assessing is nice, like with, just with your eyes, what you can see, or with a mirror, but also just feeling on those bony prominences and see if anything feels different to your fingertips is also good too.
So the wound would feel cold, not warm?
You could feel either cool or warm.
Okay.
Most of the times on the heels, there's like more of a cool type feeling, but on other parts of the body, it might be warm. They usually just, it's described as just a temperature change.
Okay, thank you.
Like a very noticeable temperature gradient change. You're welcome.
Hi there. I over the summer it was very hot, and I think I experienced some mucosal membrane issues. Well, I did experience some issues, and yeah, being super hot, and then of course the seat cushion itself is not totally breathable, and wearing any panty of sort just kind of exacerbates it. I did get burns from the panty, but I did have just more blisters because I do a lot of exercise and move around a lot. So what can I do? I tried the zinc cream, and that was almost worse trying to take it off, as a matter of fact. So what can I do to prevent, because there's a lot of sweating, well, like I say, it was hot. I was still exercising and moving around. I'm in the wheelchair, but I want to, move as much as I possibly can while I still can. So what can I do to prevent this from happening to me, like next summer, let's say, now that we're going into the winter months? I don't think that's going to be happening, but.
So actually, often we'll use with individuals, and this is with anyone with any sort of like perspiration or excessive moisture, we'll use what's called a moisture wicking textiles. So something that's big on the market that we use a lot, and I know it's readily available on like Amazon and stuff like that, is called Inner Dry. And it comes in pre-cut sheets, or even like it looks like a roll that you would roll out like aluminum foil or something like that. And you can cut it and just kind of tuck it in where there's excess moisture. So under abdominal folds or under breast folds, like underneath a sports bra or in the groin type area. And it helps to wick the moisture away from the skin. And also, in addition to that, as like a type of dressing, there are clothes that are made with the same type of material, that moisture wicking type material. So yeah, I totally understand what you're saying as far as the zinc barrier cream. And that's why I kind of like that skin prep, that acrylate dressing type that I was mentioning, because it's something that repels moisture. That's something that you don't have to really scrub to clean off, and it goes on clear. So they do sell, and it's not just skin prep, but they do sell these like friction type. It looks like a deodorant stick, and I've seen like runners use it, and they kind of just like put it all over any areas that might have excessive friction or sweating. I don't remember what it's called off the top of my head, but it's like a friction stick that looks like a deodorant. So that's kind of similar as well. But yeah, those moisture wicking textiles we use a ton in the acute care setting, and it, like I said, readily available online.
Great, thank you.
You're welcome.
One other thing that I wanted to mention with the Inner Dry was there is a little bit of risk for user error on it. So I want to tell you that you have to leave a portion of it out of the skin fold, because the point of it is to draw the moisture from the inside of the fold out. And so I've seen people just kind of shove it under a bra, and they're like, why isn't it working? And you have to leave a portion of it hanging loose, if that makes sense. Kind of like a candle wick, that part of it needs to be sticking out of the candle.
Sorry, I don't want to hog the discussion here, but I actually find it very interesting. So I wanted to ask about this Inner Dry compared to ABD pads to put on a dressing. Which one is better long-term, ABD pads or Inner Dry?
So we use more just ABD pads as like a secondary type dressing to absorb. Inner Dry is not used to absorb, it's just to wick away. So like even if you were to have Inner Dry like in a wound bed, it would just kind of like soup up in there after a while with too much like exudate or wound drainage. So definitely Inner Dry just more for intact skin, to wick away sweat and things like that, as opposed to an open wound, which needs more, which wound exudate, just in the cascade of wound healing, like all the healing factors that go to the wound, it kind of makes a little bit thicker of a drainage as opposed to sweat, which is very thin. So you need a higher level of absorbency for something that's like an open wound. So that's why we use ABD pads and things like that, just for a higher absorbency level as opposed to wicking for sweat.
And then just as an FYI, they do have for Inner Dry. Lauren, are you aware of one that doesn't have antimicrobial silver in it, or do they all have antimicrobial silver in every Inner Dry?
I think it used to be called Inner Dry AG, and it's just called Inner Dry now. I think it still has silver in it, to be honest with you.
I think it does too. I'm looking at it on Amazon.
Yeah.
And the reason why
out anymore. Oh no, I was unmuted. Sorry. I don't think that they make it without anymore. Nothing that I haven't seen anyway. And maybe we just don't get it in the hospital anymore.
Yeah, I don't see one that doesn't have silver. So, and you guys might already be familiar with this, but silver is antimicrobial for a whole slew of different bacteria. The only thing that you want to be careful with it is if you're treating an area for yeast or fungus, then the silver will inactivate the antifungal medication, FYI.
I have a question. In terms of a dressing, Inodine is cheaper than Ergotol AG for dressings, as far as I know. So when it's being used, in my experience, limited experience, it's quite effective in healing a wound. However, it tends to stick to the moisture in the wound. So I was wondering, is there any way to prevent it from sticking? Because ergotol AG doesn't, but inodine does seem to stick whenever there's excessive moisture. So is there anything that can be done about that?
I'm looking up the ergotol. Is it more like of a mesh type dressing or
Yeah, it's dark. It's darker and
is it,
can be cut to size, kind of
is
like.
it the one that's kind of like feltish and has little crisscrosses on the bottom?
No,
No.
I think that is Aquacell. This one is just very thin. It's
Mhm.
like just a very thin mesh, and it comes in about this big of a size, and it can be cut to size. So that one peels off well, but inodine, being more economical, actually works
Right.
very well. It's also antimicrobial, but it sticks. So what can be done about that? Because whenever it's in contact with moisture, it just sticks.
Usually, if we have issues with dressing sticking in a wound bed, then it typically means like if I'm gonna like you mentioned Aquacell, it's something that we use a lot. So if I'm gonna put Aquacell into a wound bed, then I'm trying to remove moisture. But if my Aquacell is sticking in there, then that means it's probably not moist enough for that dressing. So if I'm using Aquacell, then I'll moisten the Aquacell. But if it's something like that's more of a fabric, maybe more frequent dressing changes would help it not stick. A lot of times we'll use contact layers, which you kind of mentioned, which is like that mesh type dressing to help prevent sticking. But usually, if my dressings are sticking to a wound bed, I donate moisture into it where I can, or I change up the dressing more often, or when if I'm telling my patients to change their dressing at home, I tell them to do it under running water so that it'll come out easily if it's a pain management type issue.
Oh, so this one actually was sticking more after it was underwater. It was kind of really hard to remove that inodine that's yellow and kind of has is already when it's peeling off, it's moist, peeling off of the protective layer, like from the package.
Are you
Okay,
thinking possibly of the zero form dressing by chance? Because you mentioned the yellow.
Sorry, which I couldn't hear you.
My apologies. I was wondering, the Interdry is it's a gray sheet. I wonder if we're talking about the same product.
No, inodine is yellow and ergotol is kind of grayish brown.
Oh, I think we're talking about different things. Interdry. I'll write it down in the chat.
Yes, so inodine, I'm looking at it right now. It's not a product that I'm familiar with, but I'm just Googling it. So it is a PVP non-adherent dressing. I see. Okay. This is just not a dressing that I'm super familiar with, and I'm not sure what's the active ingredient. So it looks like it's kind of like that mesh that has some sort of antimicrobial base in it. It's supposed to be non-adherent. So yeah, it's not a dressing I'm super familiar with. It's made by the same company. It looks like that makes Silver Cell. So just in quickly looking it up, it's saying that a color change provides an indicator of how frequently dressing should be changed. So I guess if it's turning more white, then it means it should be changed more often. I don't know if that's something that you're experiencing when I look it up. So like,
no, it's yellow.
It's
Yellow
always
and
yellow
orange.
and it's still sticking into the wound bed.
Yeah, like it can be peeled off after about a day or two, but if it gets really moist from shower, it's really hard. Yeah.
Yeah, it's not a dressing that I'm actually familiar with.
That's okay. I thought I would ask.
Yeah, no, I'm going to look into it because it's not something that there's so many dressings out on the market right now. We use I have a good familiarity just because different hospitals use different things, but there's probably thousands. But yeah, that would just like my overall broad recommendation would just be like if it's sticking in the wound bed, and sometimes changing up wound dressings are helpful to help a wound heal as well. So like if you have an open wound for a while, I do it in my practice. If I'm not seeing any progression, if I'm just having technical difficulty with the dressing, or my patient is having issues with it, then I just switch it up. I like doing, like Aquacel is great. I like Hydroferra a lot. I don't know if that's something that you've ever seen or used. It's like a blue foam dressing.
No.
That's antimicrobial also.
Mhm.
Something, I mean, Aquacel is good, but there are silver alginates out there that are much cheaper than Aquacel. So a lot of different brands make silver alginates. And I don't know if you're familiar with honey or Medihoney. So like Medihoney has its own alginate as well. That's something I really like to use in wounds that have some exudate, need a little bit of debridement. So kind of need to remove that fibrinous gunky stuff, can be left on for a couple of days and typically are atraumatic or like pretty painless to remove. So Medihoney, and Medihoney is like the brand name, but any sort of honey alginate looks actually very similar to this dressing that you mentioned, the Inodine. So yeah, but there's just so much.
Yeah, yeah, I think so. It's not as dark. It actually has a white peel, but yeah, it comes kind of like this. Yeah.
Okay,
Yeah, it is
so Lauren, it
interesting.
looks like it's a non-adherent layer.
Yeah, I just wonder what makes it yellow like that. I just don't
It
know.
has iodine, I think.
Iodine
okay.
in it. Yeah.
Okay. And you know, some iodine-based dressings are things that like I like to use in wounds that are like pretty dirty. So like in diabetic foot ulcers, and I say dirty in the sense that have like a lot of non-viable tissue or a lot of exudate that really needs to be cleaned up. So in clean wound beds, that's why I like things more like a honey or something like that. But yeah, sometimes those iodine-based dressings, while they are economical, it's more of like a broad spectrum, like kill for bacteria. Sometimes they are a little harsher on wounds than what you might need, which is hopefully something that's superficial.
Okay. Thank you.
No problem.
Yes, I just wanted to thank you both for your time, for sharing such an informative presentation with us.
Thank you so much for having us. This was great.
Thank
And
you.
thanks for the discussion.